Good evening, ladies and gentlemen. I'm Dr. Niroshan Lokunarangoda. On behalf of I welcome you to the 6th lecture of the Cutting Edge lecture series with international faculty. May I invite the President of Ceylon College of Physicians, Professor Arosha Disanayaka, to speak a few words. Over to you, sir.
A warm welcome to all of you. Please forgive me if I speak to you from the dark. I'm still on my way home. I'm in the car. A warm welcome to both the resource person as well as those who are joining the virtual audience. This is the 6th in our series of cutting edge lectures and perhaps the final cutting edge lecture for the year 2022. The purpose of this has been, as you all know, as in the previous 5 lectures, to get an overseas expert, somebody who is really brilliant at a particular subject area, to speak to us about the very current and cutting edge type of developments in that particular field. I'm very grateful that Dr. Duncan Forsyth has decided to join us this evening. I've known Dr. Forsyth for a number of years. For those who do not know him, he has been a dear friend of the CCP over the years. He has spoken at our different conferences. I particularly remember in 2016 when I was coordinating the communication skills training program, and we had titled it Difficult Conversations. And Dr. Forsyth gave a most insightful workshop on communication skills, and many of the trainees who joined that are now consultants themselves, and they've all benefited immensely, both from clinical practice as well as exam point of view. So Dr. Forsyth is no stranger to us. He's a very dear friend, and it's lovely to welcome him yet again to the CCP. Then, of course, I must express my gratitude to Dr. Niroshan Lokunarangoda, who over the past year coordinated this program and held a wonderful series of lectures. Niroshan, I'm most grateful to you on behalf of the CCP for coordinating and spearheading this effort. Then, of course, for each one, we had different resource persons from the CCP who supported. So this evening, it's going to be Dr. Barana Villavitana, who is going to coordinate things with us. And as always, Nalina Nalina is coordinating the IT things. So please, ladies and gentlemen, have a good session. Let's learn a lot about care of the elderly. Over to you, Barana, to introduce formally Dr. Forsyth to this audience. Thank you.
Thank you, Prof. Arosha, and welcome all for this cutting edge series lecture. And Professor Duncan Forsyth needs no introduction to the CCP audience. However, as a formality, I would like to introduce him. He is a consultant geriatrician, and he recently retired from Addenbrooke's Hospital, United Kingdom, and after serving about 30 years as a consultant geriatrician there. And he's a true friend of Sri Lanka. And he was with us in the CCP sessions, SLAGM activities, as well as he has gone to various places in Sri Lanka, Anuradhapura, Trincomalee with us, giving lectures and doing training workshops in care of the elderly to our trainees, as well as not only doctors, nurses, and allied health sciences. And he has done a great job helping PGIM to establish MD geriatric curriculum, as well as training. As last 3-4 exams, he was the external examiner for MD geriatric medicine exam in Sri Lanka. And today he's going to talk to us on remote management of older patients, virtual wards and clinics. And before starting the lecture, I would like to tell you that you can ask your questions through Q&A. You just type in the Q&A box, and at the end of the lecture, we will attend to those questions. And so once again, thank you very much, Professor Duncan Forsyth, and over to you. Thank you very much.
So thank you very much, Arosha and Birana for those kind words. And indeed, I have enjoyed all of my visits to Sri Lanka and look forward to hopefully having more. I think, Birana, you've been very kind in what you've said about my commitment to geriatric medicine in the development of geriatric medicine in Sri Lanka. But I'm just a small part of the huge strides forward that you've made in Sri Lanka, and it's been a great pleasure to be on that journey with you all. So I also want to thank the CCP for inviting me to give this talk on the cutting edge of geriatric medicine. This first slide gives you the idea of the context of my talk. So in recent years, healthcare professionals have been considering new ways to respond to the acute care needs of older people with frailty and other long-term conditions. Hospital care, urgent care, will still be needed, but hospitals bring risk for older people as well as benefits. And so community-based alternatives are increasingly being explored. This has resulted in a shift in focus within the NHS and internationally towards providing hospital level care in the person's home environment. Now, while these services are traditionally referred to as hospital at home, a broader programme of work, with frailty being one of the first pathways, has recently been introduced by NHS England using the term virtual wards. So this includes models based on remote monitoring and advice, as well as the face-to-face care provided by hospital at home models. Step up, that is putting healthcare professionals into the individual's home to try and avoid hospital admission, or step down, again, putting healthcare professionals into the individual's home to try and support an earlier discharge from hospital. But whatever the model, the aim is the same, that is to provide safe, effective and person-centered alternative to hospital inpatient care. Now you might be asking, what's this slide got to do with it? So this is a recent paper from Singapore looking at outcomes of care by geriatricians and non-geriatricians in a hospital-based setting. And the purpose of this is really to just emphasize the importance of geriatric medicine, geriatricians, and the multidisciplinary teams that they work with. So the patients who were under the care of geriatricians were significantly older and had a higher prevalence of dementia and stroke, a higher prevalence of diabetes and hypertension in those who were not under geriatricians. Delirium as a primary diagnosis was higher amongst patients under a geriatrician, but despite having older, sicker, more delirious patients, geriatrician-led care was associated with shorter length of stay, lower cost, similar inpatient mortality, and a 30-day readmission rate. And the costs were lower in those who were looked after by geriatricians. So geriatric medicine delivers good outcomes in a hospital setting. So the question is, as much as politicians would desire that to happen in a non-hospital setting, can we show that it does? Now, the terminology can be confusing. It can be confusing to those who run virtual wards and remote clinics, remote monitoring, and certainly very confusing to the politicians and the managers who want these things to burgeon at an increasing rate of knots. So hospital at home services provide face-to-face care at home through multidisciplinary teams based in the community. And they are provided as an alternative to inpatient care. And they are step up, step down, as I have discussed. Virtual wards are hospital-led alternatives to inpatient hospital care and may incorporate remote monitoring through apps, technology platforms, wearables, devices, and so on. And in their simplest form, remote monitoring represents most or all of the provision in virtual wards. And that was exemplified by the provision of pulse oximetry to COVID patients during the recent height of the pandemic. Remote monitoring includes virtual wards, but is a broader term and isn't always restricted to people who would otherwise require inpatient hospital care. For example, someone who is under the local regional cardiological center and has an implantable cardiac device, defibrillator, will have at their bedside a remote monitor which interrogates that ICD every evening and can be interrogated as necessary by the remote cardiology service to determine whether the individual needs to be brought into clinic, perhaps needs advice about changes in medication because of worrying arrhythmias that the device has picked up, or if it's been firing off. So in practice, there is considerable overlap between hospital at home and virtual wards and remote monitoring. And so it's easy to see how people get confused with these terminologies, and that will come out in some of the subsequent slides. It's a continuum of care provision is the way to look at it. So healthcare systems around the world are under financial strain because of an aging population, the rising prevalence of various chronic diseases, and also budgetary constraints resulting from the global economic downturn or the mismanagement of national economics, such as has recently occurred in my country. And the costs of providing healthcare are highly skewed across the population, with a small number of patients accounting for a large proportion of expenditure. So for example, around 5% of patients in England account for 49% of inpatient bed days. And if admission rates could be reduced for these very costly patients, then large net savings might be possible, even if the costs of the preventative care were high. However, some disappointing results from government-funded trials of hospital avoidance schemes, such as the UK Evercare pilots, the Partnership for Older People pilots, and the US Medicare Health Support Experiment and the Medicare Coordinated Care Demonstration, are reminders of how difficult it can be to make these potential savings. Now, one reason why hospital avoidance interventions might fail is if they're offered to patients who are not truly at high risk of emergency admissions. For example, the UK Evercare programme, which involved a comprehensive assessment and ongoing monitoring, was offered to patients aged 65 and over who had experienced 2 or more hospital admissions in the preceding 12 months. However, today's high-cost patients tend to have markedly lower average costs and markedly fewer unplanned admissions in the future, even without intervention. And this is due to a phenomenon of regression to the mean. So indeed, an analysis of the UK Evercare programme by Gravel and colleagues showed that there was actually no reduction in admission rates above what would have happened anyway due to the regression to the mean. And an evaluation of the Partnerships for Older People's pilots, POPPS, reached a similar conclusion, again because of regression to the mean. So as Evercare and POPS studies illustrate, hospital avoidance programs may best be offered according to the risk of future hospitalization, rather than being offered to patients who are currently experiencing multiple hospital admissions. And since unplanned hospital admissions account for a high proportion of costs, considerable resources could potentially be invested in providing preventative care for a relatively small number of costly patients, and yet still potentially yield net savings overall from averted future hospital costs. So it's easy to see how managers commissioners of services can get enthralled by this as an idea. In practice, however, such savings have been difficult or impossible to demonstrate. And one reason why preventative interventions may be unsuccessful at reducing demand is if they're offered to patients who are at insufficiently high risk of future unplanned hospital admissions. So virtual wards are one such intervention. And this model of care uses the staffing systems and daily routines of a hospital ward to deliver preventative care to patients in their own homes in the aim of mitigating their risk of unplanned hospitalization. And a key difference between traditional hospital at home schemes and virtual wards is that the former are typically designed to provide reactive care following a hospital admission, whereas virtual wards seek to provide proactive upstream care aimed specifically at hospital admission avoidance. So potential virtual ward patients are identified usually using a predictive risk model, such as the patient at risk of rehospitalization tool, PARR, or the combined predictive model. And these identify individuals in a registered population who are at high risk of future unplanned hospital admission. In other words, rather than waiting for such people to be admitted to hospital as an emergency, virtual wards instead aim to take the coordination of a multidisciplinary hospital team out to the patient in advance in order to deliver multidisciplinary, coordinated preventative care in the community. So the purpose of the study, which is shown on the right of this slide from the National Institute for Health Research, was to assess the extent to which multidisciplinary case management in the form of virtual wards led to changes in the use of healthcare and social care by patients at high predicted risk of future unplanned hospital admission. Now, this slide shows you the original model for virtual wards. And I don't want to try and read through all of the bullet points. My slides can be made available to you so that you can scrutinize this one in further detail. But the original virtual ward program was in Croydon in 2006. And I want to particularly draw you to the area that I have marked round in red and emphasize the fact that patients remain in the community during their time on a virtual ward and receive multidisciplinary care, as I've said, and that's intended to improve or maintain their health status and reduce the risk of unplanned hospital admission. And the care is delivered in person at the patient's home, by telephone, and or at a local clinic. It can be a combination of all of them. And in that original model, each virtual ward had a capacity for 100 patients. So that's 100 virtual beds per virtual ward. Of course, there are beds, the patient's bed in their own home. And these 100 patients were subdivided into 5 daily beds, 35 weekly beds, and 60 monthly beds, reflecting the frequency with which different patients were reviewed on a ward round. So different levels of severity, intensity of care required. And the virtual ward staff could move patients between different bed allocations as the patient's needs change. So in practice, what might this look like? So I'm going to give you an example from Somerset in England on how a virtual ward might work. So the Somerset model comprises a community-based multidisciplinary team looking after older people, often those living with frailty, and provides person-centered care with a shared understanding of decisions. So the focus is on what's important to the person and their family to help them live the best life they can in the place they want to be. The staff have a can-do attitude, and that's very important. They don't see obstacles, They see challenges and look for ways to overcome them. And they have a willingness to help other services to build trust and mutual respect amongst the wider neighbourhood teams, enabling organisational barriers to be broken down so that organisations will come together rather than working in silos. The Somerset team takes referrals from anyone and everywhere, and the people seen are often involved with multiple services, both primary and secondary care, community, social and the voluntary sector. And interestingly, they have no fixed criteria for who they see, but they use a comprehensive geriatric assessment approach to coordinate care, get the right people involved with the least number of steps possible. The team meet virtually once a week with each GP practice in the primary care network to discuss people of concern, new discharges, and to receive referrals. And these huddles are the MDT meetings and last for between 30 minutes and an hour each week. The team also meets once a week with their wider community partners such as social care, care coordinators, link workers, pharmacists, mental health workers, district nurses, dementia support workers, discharges services from hospital, etc., etc. And there's a flat hierarchy in the meetings. So it's a safe place to ask questions, to share responsibility, learn from each other, and ensure good care for the people that they're looking after. Every other week, they meet with the consultant geriatrician who supports them as needed, and they can also follow up patients from the frailty clinic in the community. And each month they have meetings with the memory service and also with the Parkinson's specialist nurses, as many of the people looked after are known by multiple teams. So a CGA, a comprehensive geriatric assessment approach, means that they can make management plans to proactively support people and their carers. And this structure supports dementia reviews, looking at medications, social prescribing projects. And they also, interestingly, train Foundation Year 2 doctors, providing these trainees with an absolutely invaluable insight into community working and life outside of a hospital setting, and how different that is. So coming back to this study by the National Institute for Health Research, there were 3 sites included in this: Croydon, Wandsworth and Devon. And each had actually implemented variants on the virtual ward model, which is a bit like going to 3 departments of geriatric medicine and seeing how they do things. The fundamentals are there, but each department will interpret it slightly differently. The vast majority of cases came from only one site, Croydon, and that's a problem with this study. And another problem is that initially Croydon had a multidisciplinary preventative care approach, so a true virtual ward. But after an initial pilot, they changed to standard case management by community matrons. So it wasn't a virtual ward in the end. So the study findings predominantly related to patients who received standard case management by a community matron rather than multidisciplinary case management from a virtual ward team. Now, in the 12 months before receiving the intervention, the virtual ward patients had higher rates of emergency hospital admission, so they were a vulnerable group. They had more general practice visits. They were much more likely to have been in contact with community nurses. They had more recorded chronic health conditions, so they were a frailer group than the rest of the population. And they were more likely than the rest of the population to have received social care input. Now, based on a comparison of activity in national data for pairs of cases and controls, this study showed no evidence of a reduction in emergency hospital admissions for patients admitted to the virtual ward during the 6 months after starting the intervention. And there was no evidence of a reduction in ambulatory care sensitive hospital admissions during this period. There was a reduction in elective admissions and in outpatient attendances. And there was no evidence of an overall reduction in hospital costs. So it was quite a negative study, but then it wasn't actually looking at virtual wards in the end. So what other evidence is there? Well, it's mostly from hospital at home rather than virtual ward models. So mostly from admissions avoidance and early supported discharge models, step up and step down. Now, these admission avoidance and early supported discharge models give similar outcomes to acute hospital care in terms of mortality and benefit. There may be lower institutionalization rates, and length of stay is actually longer with step up hospital at home. And the question that's raised is whether this is due to better identification of unmet need. What comes out from these predominantly studies of hospital at home is that patient selection is crucial to outcomes, as are staff competencies and organizational structure. Most cost analyses do not take into account the cost to the recipient and their family, which can be considerable. But they are cheaper for the system. And this is, of course, why politicians, managers are crying out for us to start them up. And patient satisfaction is hard to judge, as it's a highly selected group. They've got to want the workforce to come into their home, because one of the general selection criteria for these projects is, are you happy for the workforce to come to you rather than you go to the workforce? I'm going to change tack. And I'm going to go to virtual clinics next. Now, just before the UK and indeed the world went into meltdown over COVID, the NHS England produced its long-term plan for reducing footfall in the NHS. And the aim was to avoid up to a third of face-to-face outpatient visits over a 5-year period, removing the need for up to 30 million outpatient appointments each year. Now, COVID just put this into overdrive because we were not able to see patients. And so we had to move pace to virtual consultations. And this schema from the General Medical Council, I apologize that when I photographed this to make it into a slide, I didn't realize that I was getting a shadow from my arm on it. But this is to show how we should weigh up factors to decide whether we go for remote treatment or whether a face-to-face appointment consult is necessary. So on the left-hand side, you've got these 6 boxes saying, yep, a remote virtual consultation may be appropriate. So the clinical need or the treatment that may be required is likely to be straightforward. You've got access to the patient's medical records. It's likely that you'll be able to give the patient all the information they want and need about treatment options by phone, internet, or video. It's unlikely that you will need to examine the patient. You've got a safe system in place to prescribe virtually, and the patient has capacity to decide about treatment. Now, having done some virtual consultations with people with dementia, I would say that that capacity issue could also be proxied to their carer, as it is in face-to-face consultations. On the other hand, a face-to-face consultation is likely to be more appropriate if the patient's got very complex clinical needs or is requesting high-risk treatment. You're not their usual doctor and you don't have access to their records. You're flying blind in terms of what's gone on before. If you need, definitely will need to examine the patient. So a colorectal surgeon is not going to be able to do my rectal exam virtually or my colonoscopy. If it's hard for you to ensure by remote means that the patient will have all the information that they may need, and if you're unsure about capacity, well, I've dealt with that. I don't think that's quite as clear-cut as the GMC are making it in this division. But clearly, potential benefits of virtual clinics are many. It assists in provision of care closer to home, actually in the home. Although I have had 1 or 2 elderly patients who needed to be taken to their sons, who has the tech, in order for me to do the virtual consult. And that means that they've also got a techie on board with son as part of the consultation. It may improve patient experience. It may save time. It can meet population health demand, and it may develop a resilient workforce, a workforce which is comfortable in communication, can do that through any medium. It may improve care, it may not. And there is, of course, as Greta Thunberg would be delighted to know, a reduced impact on the environment by the reduction in number of car, bus, train journeys. There are risks. The evidence base for this change in practice is in its infancy. It is growing, but it is still in its infancy. And potential risks, which are very evident in stories that are now coming out as we move away from the global pandemic of COVID, are of poor patient management, missed or delayed diagnoses, which can lead to fatalities. And there is also a concern about potential breaches of patient confidentiality if you have unsecured networks. Is Big Brother actually listening to you, monitoring you? Can they hack my Zoom calls, my WhatsApp calls, however I'm doing these virtual consults? Now, in the UK, as in many countries, life during and immediately after COVID was that although healthcare provision was still available, we were saying to people, but only come and see us if it's essential. And so there was this demand for, well, you know, if we don't think it's essential and you don't think it's essential, how do we still get some healthcare input? And also what COVID told us was there was an urgent need to put the NHS future plan into action to provide healthcare differently. Now, in conversations with geriatricians, with non-geriatricians, the initial view was, amongst many people, it won't be possible. I felt it would be possible, but I was conscious that there were likely to be problems. Particularly, I realized I fell foul of an ageist bias, thinking that my older patients wouldn't be able to do the tech. But then reassured myself that in ward rounds through the 20 teens, increasingly I'd noticed older, and I'm talking 85+ with smartphones, with iPads, doing FaceTime calls with their relatives while they were in hospital, telling me that they did internet shopping and so on. So the older generations are more tech savvy now than previously. So the reality, my experience was, it was a darn sight easier than I thought it would be, and very much easier than some of my colleagues thought it was going to be. Provided it was a video consult, it was useful. Telephone consults really were just a bit of social reassurance. Hello, how are you? Thank you very much, Dr. Forsyth, for calling. It's lovely to know that someone cares, and to hear just another voice and know that the world is still ticking over must be terrible for you in the NHS at the moment. Clinically, they were a waste of time. Now, it was important to give consult advice to the patient, so to make sure they were happy with a face-to-face, with a non-face-to-face consultation. and reassure them that I would be in a quiet, secure environment, and find out what kind of environment they were going to be in. That there weren't going to be grandchildren going to be around. Of course, there wouldn't have been during COVID, but subsequently, that they didn't have a dog that was going to be yapping in the background all the time, or leaping up and knocking the laptop, the phone over. To know how I was going to contact them. So what sort of tech did they have? Make sure they knew when I was going to call, so that they were there and hadn't gone out to have their hair done, or weren't having a nap. I encourage them to have a family member present if they could, so spouse. And I've always asked them to bring family members to their outpatient consultations, but when they were face to face, because two brains are better than one, usually. Remind them that it would be a good idea to wear their hearing aid, and if they had voice to text app, to let me know they were using it. Voice to text apps have improved remarkably. My brother-in-law, who spends most of his time in the States, has a wonderful voice to text app, which has just revolutionized our ability to communicate with him in the US, as he has grown to find his hearing aids increasingly useless. Make sure that they've got medication or a list of it by the phone, computer, whatever tech you're using, so that they don't partway through the consultation have to wander off when you say, so what pills are you on? Are you still taking this? Let them know roughly how long the consultation will last. This is not going to be a 3-hour conversation by Zoom. This is a half-hour appointment, 10-minute appointment, an hour appointment, whatever. And if they're using their phone, then make sure that they've got one of these to hold. Let me get it into, to hold their phone, so that their arm doesn't get tired holding it and the phone droops. And if they've got tremor or dyskinesia, the phone's not going all over the place. Of course, virtual consultations by video start as soon as a video link is established, just as an outpatient consultation starts face-to-face as soon as you can see the patient. And after history taking, observation is, of course, our key diagnostic process. So it's not surprising that you can do an awful lot by video consults. For example, have they followed the advice given pre-consultation is quite a good test of executive functioning. Some need tech advice. If you're using video on your phone, you do not need to hold the phone to your ear, although I'm delighted to see that there's not much wax in your ear, and I see you're not wearing a hearing aid. I want to see you, not your eyebrows, up your nostrils and the ceiling. I want to see you. I don't want to just see your right ear. And those are interesting photos behind, which are going to distract me. And at some point, we're going to talk about them. If you've got your wife, your son present, you may not both be able to come on screen together, but let me know they're there and put everything on speakerphone. So that I can hear them, they can hear me, and I can tell them when I want them to intervene and to talk to me and when I don't want them to. Having a relative present gives corroboration, as it does with a face-to-face consult, and you can check whether the history is making sense, and also with the virtual consultations, is the patient actually answering the question. Now, I've mocked this up for a neurology clinic, but of course, the questions, the focus of the questions might change in a cardiology clinic. And I'm not going to insult you all by reading through the questions that you ought to ask in a neurology consult. The purpose of these next couple of slides is really just to point out that, you know, it's no different to doing a face-to-face consult in this respect. And whilst asking about alterations in speech and so on, there is plenty of opportunity to see whether the individual is fluent in language, whether they have any evidence of inattention, are they looking out of the window easily distracted, do they have cognitive impairment, and so on. We take the neurological examination as possibly the hardest examination that any of us ever do, mainly because most of us don't accurately tell the patient what to expect, and many of us are nervous in our neurological knowledge base. This is showing you what you can do virtually, and it's pretty much all of the neurological examination. I'm just going to go forward a minute. No, I'm not. What you can't do is you can't do power, tone, and reflexes. Well, I've been waving my arms about while I've been talking, and I've been moving, which should give you an idea that actually I'm not akinetic rigid, and that my movements are quite fluid, and that I can use both upper limbs. Now, before proceeding to any further examination, this would be a good point to decide whether you want to formally test cognition. But it should be clear by now whether this has been a fluid consultation so far, or whether it's been disjointed, and you suspect or are absolutely certain that the individual has got cognitive impairment. Now comes the tricky bit, because to examine me from a neurological perspective, you want to see me get up and walk, maybe undress, perhaps do stairs, turn around. So you need the person who's in the room to film this for you. So you've got to be able to instruct the family member, the carer, where to stand, explaining both to them and the patient what it is you want to see. Joan, I want you to stand behind Duncan now in that corner, and I want you to make sure that the video camera is on, looking at Duncan. And Duncan, I want you now to get up out of the chair and walk across the room, turn around and come back. Joan, the phone's angling up a little bit too much to the roof. Can you just angle it down a little bit? That's fantastic, Joan, hold it there. And be prepared for several takes. Quentin Tarantino, I'm sure, didn't make any of his films all in one take. There's an opportunity again here to see whether people can follow instructions, but bear in mind that they may not be following instructions because you're not clear in giving them. So this is also a bit of a communication skills exercise. And I've shown here some of the things that you can get out of. And in geriatric medicine, this would be a timed get up and go, looking for postural instability, turning through 180 degrees, doing a timed 5, 6, 10 meter walk test. And you can do other parts of the neurological examination, including looking for wasting of circulation. But as I've said, you can't do power, tone, reflexes, and obviously you can't test sensation. You may want to consider teaching the carer how to measure lying and standing blood pressure, and then they can email it to you later. So do you know how to teach? Do your trainees know how to teach lying and standing blood pressure? Is a good question from this. So bringing the consultation to an end is no different from bringing the face-to-face consultation to the end, in summarizing the issues, let the individual know what you think the diagnosis is or might be, whether or not you're going to need to see them because there are things you do want to examine. Will you be recommending tests? If so, which, when, how will they be done? Are they happy to have them? And what's the next step in terms of any follow-up from yourself? Bringing this talk to a close, I would quote Socrates, that the secret of change is to focus all of your energy not on fighting the old, but on building the new. And do it in calculated steps. So a virtual ward is a time-limited service enabling people with an acute condition or exacerbation of a chronic condition requiring hospital-level care to receive this in the place they call home, their own home, the annex in their children's home, the residential care home that they live in. And it's an alternative to hospital admission by facility or to facilitate an early discharge from hospital. And it delivers a variable combination of remote monitoring, face-to-face treatment in the person's normal place of residence by specialists from hospital and community teams working alongside each other. And chronic care and end-of-life care, which would normally be provided by primary care in the UK or by community health services, are not considered to be part of a virtual ward. And virtual wards are not there to provide social care for patients who require support to return to their normal place of residence. This is 9 practice points for virtual wards. I'm not going to read through them again. When my slides are available to you, you can go through these. But I just want to highlight number 9, ensuring that the use of digital technology doesn't exclude any patient group and offer alternatives should patients lack the ability to fully use the technology. And this is particularly relevant also within a healthcare setting. It was very difficult for me to find somewhere within Addenbrooke's where I could do virtual consults using my phone if the individuals only had access to WhatsApp. It was sometimes difficult for me to do Zoom calls from my hospital consultant room. And often I would end up doing the virtual consults from home because it was just easier to use my network at home. So it's the IT infrastructure within your hospital setting. Home care is not for everyone. Be sure who your service is for. Be sure that the recipient and their family find it acceptable. And use this DOT acronym suggested by Patricia Cantley of, can they get a drink on their own, or do they have someone who can get it for them? Can they cope with a visit from the team only once a day? And can they get to the toilet on their own, or do they have someone who can help them? So DOT, to identify individuals who could be cared for in their own home. Develop and look after the workforce. Working alone in someone's home will be a new experience for many and can be stressful and unnerving. It's not the same as working in a hospital ward, in a hospital setting with everyone around you at the time. So you'll need to ensure appropriate clinical leadership and governance is in place, that there's competency-based approach avoiding assumptions about professional boundaries, and that there's early investment in workforce development. I've seen a lot of these community services brought up quickly, insufficient support of the staff who are being asked to do things that they've not previously been trained to do, and everything has collapsed. Appropriate use of technology with training and supervision, and an incremental approach. Learn to walk before you can run. Hold politicians at bay. Cross-agency, multi-agency relationships, respect, working together. Remember that the evidence for use of technology is from monitoring chronic conditions, not, I repeat, not from treating acute problems in the home setting. So there's a lot of research still to be done there. What's a reasonable caseload? Is that caseload that was shown in Croydon reasonable? No one really knows. I would say if your staff say, this is all I can manage at the moment, don't push them to do more, you'll crack them. So don't stretch both human and financial resources too thin. And what I think is very relevant for Sri Lanka is that anecdotal evidence from British Geriatric Society members in Scotland says that hospital at home virtual wards are much easier to deliver and sustain in urban rather than remote areas. And then finally, this rapid synthesis of what has happened with virtual clinics through using COVID-19 as a catalyst. There were only 9 studies and 975 patients which were capable for a rapid synthesis, gave enough data. But the conclusion of this systematic review was that virtual geriatric clinics demonstrated evidence of productivity, benefit to patients, cost effectiveness, and patient satisfaction. And that in the current suboptimal post-pandemic climate, virtual geriatric clinics may allow geriatricians to continue to provide outpatient services despite the encountered inherent challenges. And I would echo that. I would like to thank you very much for your attention, and I'm very happy to take any comments or any questions. And I presume that the conference organizer will now stop sharing my slides, and thank you. Back to you, Barana.
Yeah, and thank you very much, Prof. Duncan. And it's a very new area. It's relatively new area to Sri Lanka. I think during the COVID pandemic, we also used different modes of virtual sort of consultations to communicate with our patients. And thank you very much for sharing your experience and telling about the challenges and the models that we use in UK. And there are a few questions actually. One is, how can you do an assessment of a patient's capacity virtually?
The same way that you would do it face to face. So what's the issue that you are assessing capacity on? Because capacity is issue specific. What's the information that they need in order to come to a decision? Can they retain the information that you are giving? Are you able to give it in a simple format, the simplest format for them to be able to understand it, to weigh it up and to come to a decision? And can they then communicate that decision to you? The difficulty will be where you have to write out the information for the individual. But there are ways around that. You can send them written information, perhaps have someone with them, if appropriate, who can confirm that the individual has been able to read it. And of course, bear in mind, whatever is the literate age or average literate age of your country. So in the UK, the average reading age of a Briton currently is about 8 to 9 years old. So you have to provide information in language that an 8 to 9 year old would understand. And that shouldn't be insulting to the professor of health economics or whoever it is actually is at the end of the phone. They should be able to understand it equally. But you might send them you'll appreciate that this is simple information written out for the average individual. If you want more detailed information, I'm happy to give it to you in the level of detail that you want. So I think it's easy. I think it's not, it's not that difficult.
There's another question actually. How is your plan of management brought into action after a virtual consultation, such as change of drug doses, addition of new drug, etc.? How do we make sure it is done correctly?
Well, if you've got a community backup team, then so let's take Parkinson's disease as an example, because I had a very well developed Parkinson's service with community Parkinson's nurses. I could ask the community Parkinson's nurse to go and visit the individual to check that they had understood the advice that had been given and had they enacted it. In England, after any consultation, since the early 1990s, we have been required to offer the patient the opportunity to have a copy of the letter that we would be sending to their general practitioner. Standard practice for me after any consultation, be it Parkinson's or otherwise, would have been to say, and I'm going to send you a written summary of what I have told you and what my advice is. And in a country where I don't want to create work for myself, so I didn't write one letter for the patient, one letter for the doctor. I wrote a letter for the patient that then went to the doctor. So it was a simple letter for the patient to understand. And doctors, although they like to think that they're very highly intelligent individuals, should be able to understand that simple information. I've been quite intrigued recently by some very simple information that has been delivered from a cardiology service to some members of my family, instructing their GPs for what the family members need. And it's actually it's a referral letter to a cardiology service already written out, and all the GPs have to do is to put the patient's name on the letter and send it to the cardiology service. It is astounding how difficult some of the GP practices have found that. You know, my 8-year-old grandson can follow the instructions, but people who've been to university for, you know, for 8 years can't.
Another
Hope that
question:
answers
how do you get the MDT involved in the management of a patient virtually? MDT team involvement.
So if that's as a virtual ward, then it's a hospital-based service coming out to the individual. So they meet in these huddles. And of course, there's no reason why you can't have virtual meetings as we are having with your MDT team. So through the pandemic, I had virtual sessions with the therapists and the community nurses who worked with me. So we were all on the same page in terms of what needed to be done post lockdowns, when we were able, you know, everyone was getting back to work and the community nurses were able to go out and see patients again. We were in a situation where we still weren't allowed to meet up in teams within hospital. So that our virtual MDT huddle continued. So it's about having lines of communication and agreeing one on a regularity. So that Somerset example of, we're all going to meet up once a week on a Tuesday morning at 9 o'clock for an hour. But if anything crops up in the intervening period, we've all got a WhatsApp group or a FaceTime group, whatever. There are other ways of communicating. So there was a level of communication, if you like, a hierarchy of communication with my team members, which was, it can wait until next Tuesday. It can't wait until next Tuesday, but you don't need an answer immediately. So you could email me. And you know that by and large, I read all my emails every day, and by and large, you'll get an answer tomorrow. But if I'm behind on my emails for some reason, it wouldn't matter to you if it was the day after. You actually want an answer now, but you don't need to break into, as in today, but you don't need to break into whatever else I'm doing. So a instant message an SMS message would do, Duncan, this is a problem. Could you call me back, or could you just tell me what you want me to do? Anytime today, we'll be happy. And then you're with the patient and you want an answer now, phone me. So there are plenty of ways that you can ensure good lines of communication and that the service is delivered as you want it to be. But it takes organization and it takes commitment, and it also means that everyone is comfortable with those methods of communication and can be trusted to use them appropriately. Not everything, if the one member of the team is always ringing you saying, you know, it's absolutely urgent, but it clearly isn't, they need support and education and, you know, perhaps a little bit of further training.
Another question, and it's a comment as well as a question. This can be used even for non-elderly. That's the comment, and it said, can this aggravate ageism? If healthcare professionals use this more for elderly to avoid spending a lot of time with them?
Yeah, so I suppose so. But I think, you know, because geriatric medicine is in its infancy, I don't know whether yet you're getting these comments. So, you know, ageism is around in the National Health Service, and often a comment to me, to my colleague geriatricians around the country would be, you know, Dr. Forsyth, you're the first person who's listened and taken the time to listen to me. So I think something that characterizes geriatricians, and certainly I wrote this into national guidance for the British Geriatric Society, is that when, you know, if you're a cardiologist dealing with dysrhythmia and you're running a dysrhythmia clinic, everyone who comes to that clinic has got a dysrhythmia. So it's quite easy to run a clinic on 10, 15-minute outpatient follow-up slots. Whereas in geriatric medicine, you know that people are complex, that they may have cognitive impairment as part of that complexity, and you can't do it in 10 minutes. So a follow-up appointment slot, my recommendation nationally was that it was 30 minutes, and a new patient appointment slot for complex geriatric medicine, my recommendation was it was an hour. And it was interesting that the RCP eventually moved to very similar definitions, although I think reduced the hour to 45 minutes. And clearly there are other specialties that require you know, longer periods of time. But if you give people a short period of time, whether that's virtual or real, face-to-face, then there's a danger of disservice. My eldest daughter is a doctor. She's a pediatrician, and she does virtual clinics. And when she and I talk about these, she's training to be a community pediatrician. I wanted her to be a community geriatrician, and she insulted me by going to the other end of the spectrum. When I talked to her about her clinics, they're very similar to mine. These are complex kids, complex families, and they need a fair amount of time. And she gives the same amount of time virtually as she does in face-to-face consultations. So it's up to us to stamp out ageism, you know, anyism whenever we see it. It's got to be good. The service has got to be good enough for us.
Another question is this a team based in community or hospital, or are they a part of community team, or this the hospital team? That's
so it depends what model you're going for. So hospital at home teams are community-based teams, whereas the true definition of virtual wards is that they are hospital-led, but include the community teams. Now, there are various ways of cutting that. One way of doing it, which was variably successful in models that I've seen, is that the major part of the virtual ward round was actually community-based. And the geriatrician came out from the hospital to support it on a monthly basis. And that I've seen work, and I've seen it fail because the geriatrician didn't always turn up, or when they turned up, the community virtual team didn't know how to use the geriatrician properly. With the advent of community geriatricians, so Cambridge has 2, then it's possible for the community geriatricians to be the one who support a community virtual ward team. But if you need some access to the acute hospital, because some of the individuals, in order to avoid admission, will need, you know, tests, and you need a route in to be able to organize those tests, you know, fairly swiftly. But I think what you have to do is look at what resources you got and to look at how you can best distribute them. And who, you know, resources, we tend to think of that as being people and places and equipment, but it's also up here. You know, what's your mindset? How comfortable are you working away from a hospital? It can be very lonely, it can be very, very frightening, and you need to be very confident about your competencies and what the boundaries are in terms of what you can actually manage in safely in remote circumstances.
Okay, one final question, and regarding the confidentiality as well as like there are a lot of data protection acts in UK, how those apply in these virtual wards and clinics?
So there was, when I started doing virtual outpatient consults, I was ahead of Addenbrooke's in terms of getting everything set up. So the NHS wanted us to do it, but they hadn't set up a system to enable us to do virtual consults, and I wasn't prepared to wait. The system that they eventually set up was as secure as any NHS system is. But there were a lot of criticisms from both staff and patients that it was cumbersome and very difficult to use. I jumped ahead and said, I'm pretty sure that the vast majority of my patients are going to have a smartphone. And if they've got a smartphone and haven't already got WhatsApp on it, they'll have a young member of family who, even when during lockdown of COVID, that member of the family would be able to advise them how to load WhatsApp and to use it. And so WhatsApp is encrypted. And I discussed this with several colleagues and said, you know, I can understand that there can be a potential for data breach, but really it seems to me very small. And I was very comfortable using WhatsApp. I made sure that the patients were comfortable using WhatsApp. And I'm not aware of there having been any data breaches. And one fear that my colleagues had was that, Duncan, but the very nature of you doing this means you're giving out your mobile phone number to all of your patients. And I said, you know, I trust them. What I think that what they will see is that I'm doing my level best to offer them a service of continuity through a terrible time for the world and for our country. And I don't think they'll abuse it. And indeed, none of them did.
Thank you very much. Actually, we have come to the end of this talk. It's a new era. It's relatively new thing into Sri Lanka. Actually, we have used, even especially in private sector during the COVID, as well as in the government sector in the COVID era, we use these sort of modes. But thank you very much for sharing your experience and giving your comments for the questions we asked from you. And thank you very much. And thank you very much for sharing. And thank you very much all the participants who were with the in the live discussion with the Professor Duncan Forsyth. Thank you.
A great pleasure. Lovely to see you, Barana. And thank you very much again.
Okay, thank you. Right.